guys, thanks for joining. This is Essence of Medicine. Today we're going to be talking about infection control. My name is Amanda Armagoss.
My name is Alyssa Hopper.
My name is Mike Yeager.
And I'm Dr. Abbasi. I'm here just to wrestle arm with Mike.
I'm sure you can tell he's a little bit hyper. We need to get this energy out. So first, before we start, Alyssa, who do you think is gonna win? We're gonna do an arm wrestle competition between Mike and Dr. Abbasi.
Well, I never go to gym, so you know.
And as you can see, look at Mike's muscles.
Wow, yeah, look at him. Look at him. You know,
Big.
Yeah, I have to come too, you know.
So Alyssa, who's gonna win this arm wrestling competition?
Well, do I want to go with the person that signs my checks
No.
or the person
no.
that I
Well, it is.
if I do see correctly, I did watch your at-home workout that you posted.
Which one?
The one with the fingers.
30 seconds.
Yeah, I've
That
seen
doesn't
you
count.
work out.
Okay, let's
So
get it out of
Okay,
here.
so Alyssa, who do you think is gonna win?
all right, sorry, Mike. I gotta go with the big dog.
Hey,
I've
you
seen
never know.
I've seen Dr. Abbasi wrestle Kurush, and he has really big muscles too. So sorry again, Mike. I
God, I'm
have to
glad
put
you
my
saw
money
that.
on Abbasi.
Okay, I don't know if Mike can actually
Give me 20 bucks.
go for him.
Give me 20 bucks.
Yeah, but Dr. Abbasi is in surgery all day, just
I know. I've seen him with the hammer.
hammering. Yeah.
Oh, wow, Mike, you have muscle.
Right.
Oh, whoa, chill.
Ready?
Wait, hold on. Let me show your
Well,
TikTok.
My hands are like
Sweaty? I would be. I'd be nervous.
okay. You count.
3, 2, 1, go.
Wow, he's very strong. Oh my God. Let's go do the other one. He's very strong.
I
man.
know. I see those
I
muscles.
usually don't feel people, but I feel him. He's
Your chair move.
no go.
yeah, it's
Ready?
you
Ready?
do something. I don't know.
Ready?
Yeah, ready.
Go. Wow, he's very strong. Oh my God, Mike.
I see those
You are
muscles.
very strong. Oh, wow, I'm very impressed, Mike. Good job,
Good
I
job,
Mike.
see.
guys.
I wasn't so confident though.
Okay.
Wow. No,
I have full confidence that Mike was not going to
No, I was.
He's trying to keep his job.
the secret is
Yeah, what's the secret? Because I could tell you.
He
Yeah,
is
you got
strong.
some
You've
leverage.
seen him hammer.
Yeah.
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 The secret is I used to be a climber.
Mm.
I used to, you know, and when I used to be your age, I would go climb and I would use the tip of two fingers to do pull-ups.
Mhm.
And so on just two fingers, I could do, you know, push-ups on two fingers. This is still the remnant of my youth. And
It's
only
forms. Yeah.
and only 3 people in my life have beaten me on arm wrestling. And they were 3 times your size, Mike. No offense, but
No, that's,
they were 3 times your size, those 3 people. And people always, you know, but another thing is that I put lots of screws
Mhm.
in the war.
Mhm.
So my starting youth and my war, putting all those screws in, still have kept me there. But that's the only place I'm strong.
Whoa,
Everything
whoa.
else you can beat me.
No.
Well, wait until
not true.
I get in the OR and start putting some screws in. I'll catch up.
Yeah, you catch up.
Catch up fast.
But before you catch up, you need to know how to deal with consequence of surgery. So what are we talking today about?
Infection control.
It's supposed to say.
Infection control.
That's
Yeah.
all right.
Now to be clear, is actually that I wanted to see if maybe Neil can join us and ask as well some other question. I'm not sure, Neil, are you there? If you are there, let me maybe we can send you or just we can maybe email Neil.
I'm just gonna call him quick.
Yeah. So we are not going to talk about a viral infection, and we are not going to talk about fungal infection. We are going to talk about perioperative infection control. And both of you are going to take care of lots of our patients. And let's just talk about the spine as well. Be specific about spine because that has bearing on you. But the information you gather here has lots of, you can transfer lots of that information to any kind of other surgery and overall to medicine as a whole. Let's talk about what infection is. No, everybody thinks people think they know what infection is,
Mhm.
but why don't we define it? We start ladies first.
I think neurosurgeons first.
No, well, I know, but
I know.
we want to talk about it. So let's tell me, when you say somebody has an infection, what do you mean by that?
In my general sense, it would be when a bacteria or organism comes into your body or is in a place that it should not be.
I think that's a very good definition in the places that it should not be. Would that surprise you to tell you that there are always bacteria, always, every moment in your life in places they should not be?
Oh, that wouldn't surprise me at all.
Would that surprise you? If I tell you right now, there are about 100 times more bacterial cell in you than there are human cell in you. So you're practically a bacteria soup with some human cell interspersed in that. Would that surprise you?
That surprises me a little more. Yeah.
You know, bacteria are much smaller than our regular cells.
Right.
What that means is that you can fit like 10,000 bacterial cells in one human cell.
10,000?
Yeah,
Wow.
because bacteria are so much smaller. Do you know the actual size of a bacteria? Is the mitochondria, you know mitochondria, right?
The powerhouse of the cell.
Yes, excellent. Now, there is actually a story that a long time ago, a bacteria went into another cell, and then they found out, wow, we can work together so much better. And then the bacteria lost most of the other things to live, can live only inside of a cell, and the cell lost its ability to create ATP from glucose because look at that bacteria is doing it so well. They are specialized. This cooperation is the life as we know it today. Lots of bacteria in your body are in a symbiosis with you. So not every bacteria inside of you is an infection. And so I like what you said, in the places they should not be. So let's
or the quantities that they should not be.
Absolutely. I think that is the second thing I was going to say that really sums it up, like salmonella. It's bad, right? But
Can be.
well, it is
Can it
all
be
about the
good?
quantity.
So salmonella, yeah, I actually used to do research on salmonella.
Yeah, go ahead.
specifically.
Tell us about it.
Yeah, so salmonella in particular, we don't really think of it as a symbiotic organism because it produces toxic chemicals on the outside of its cell membrane. So pretty much regardless of where we have salmonella, even if it's in our gut, it'll start destroying the good bacteria and taking over their resources, and also it'll release toxic chemicals that make us sick.
Yeah, so it's a bad agent.
Mhm.
But what percent of bacteria are bad agent?
A very small percent.
Less than 0.1%.
Mhm.
So, and those that are bad agent, in a way, the most successful bacteria are not those bacteria that harm us, because the best way to, is to cooperate, give us something so that you become part of us. What are those bacteria that are part of us?
Our microbiome.
Microbiome.
Good.
Excellent. And you have two different microbiome. And did you know it's like your fingerprint? It's specific to each person. You have two microbiome. One is inside of you, one is outside of you. And it's so important to you that your body has created a method to keep a vault, like a small little area inside and outside, so you can repopulate, because you used to get sick all the time and so on. That vault has a lot of immune cell around it inside of you, and is a place that if you have a diarrhea, you get rid of everything and then it repopulates your guts. You know what it's called?
The appendix.
Appendix. For a long time, we had no idea what it is. And now we know it's where it keeps a vault of good bacteria in check, that if everything goes through and repopulate. Do you know what that vault is outside of your body?
The belly button.
Absolutely. And nobody wants to admit it, but the thing of human is people love their own smell. I mean, you know, people love their smell of their own fart.
We do?
Do
Come on.
maybe only you.
Yeah, that's what you.
He's the fart obsessed one here.
Even Dr. Nick, even in Austin Power, the fat bastard was
good.
making that joke that, you know, it is like magic. You love your own fart. So it is a non-fact, but that people, what they like to do, like, this is, I mean, it doesn't sound right, doesn't sound good, but people put their finger in their belly button and then they spread to the rest of their body. This is a healthy habit to spread your microbiome where it belongs to. Now, your microbiome that's good for you might not be the best for somebody else, but this over the millions of years, it has developed in a balance with your body.
Where on your body, like, are you supposed to put it?
So you do it automatic. It's not where you're supposed to put it, but on your skin, and we were just talking about that, there are more bacteria cell in your body than your human cell by a factor of thousands.
If you have like a rash or an injury and you put your finger in your belly button and then rub it on the rash, will it help it heal?
No, I don't know anything about that. I wouldn't recommend that. But what it means is, see,
Clean your belly button out.
Never.
no, well, you know, you're not supposed to clean your belly button very aggressively. They don't recommend that.
Aggressively, yes. I
Yeah.
recommend cleaning your belly button out.
Okay, well,
And
let's
let
put
the
it
water
this
hit
way.
it.
There will be bacteria inside and outside of you. It's not a question that there is no way you can get rid of them. Now, do you prefer them, that bacteria, to be things that over millions of years your organism has come to peace with, or do you want to just clean it up and let the air decide what should be there?
Yeah, let the OGs stay.
So infection is when they are in the wrong place and wrong number, and as well for some agent, they're always the wrong place and wrong bacteria. But then it's a question of how many, because if you have like less than a million salmonella, your body says, okay, whatever, come give it, bring it on.
Yeah.
But when it's your immune system is overwhelmed, that is when it becomes a clinical infection. So let's talk about, like, we are in a surgery. You have certain kind of bacteria on your skin that usually are what let's talk about the gram positive, negative, and so on. What is it? What is a gram positive versus gram negative?
So gram positive is a bacteria that has a really thick outer wall around it, and then it has a thin inner cell wall on the inside as well. So they're a lot more resilient and better at living in places like our skin, on top of our skin, or in the soil.
It is practically a kind of sugar on the wall of the bacteria that if we stain it, some of them they get stained, some of them they don't get stained. And that is what gram positive versus negative means. And it is important because that's the first thing we could find out about how to distinguish between a group that are positive versus negative. And then that was the first categorization we had for bacteria. It has, though, having that sugar in their cell wall, it's important because we know that most of the antibiotics, they damage that cell wall of the bacteria. And having that sugar make them susceptible to different kind of antibiotic. And it's as well very important, our body, our cells, they don't have the same wall, cell wall, meaning that something that attached that structure can only harm the bacteria and not our cells. And that is actually was the beauty of most of the antibiotics, starting penicillin, that we can harm bacteria without harming our own cells. How was penicillin found?
It was on a moldy, I want to say it was a moldy piece of cheese. I can't remember what it was.
Not a cheese.
It wasn't a cheese.
It wasn't found by a farmer or by
No, I know it was just on accident. It was growing somewhere, and
Flemings, Alexander Flemings. Now, what he found that he went for a vacation. When he came back, he had these bacterial cultures, and he was trying to find different things. And bacterial culture, like agar, or blood agar, and so on. They take a little bit of a bacteria, they go this way, and they dilute it. They do go 3 times, and then they can have individual colonies of the bacteria. So he goes to vacation, somebody doesn't do their job, he comes back, and he sees the damn agars are moldy, okay? And everybody else, that is where Locke prefers the prepared. He comes back and he sees some of them are moldy. Everybody else would have thrown them away. But he looks at that and says that those that are moldy in certain distance to the mold, bacteria are not growing. Now, he saved more life with that discovery than you can imagine. Just about 50 million people in World War II were saved by us having the idea that, listen, bacteria and fungus are competitors. But you have a piece of meat there, bacteria wants to eat it, the fungus want to eat it. So it's a natural war. So the fungus produce something that suppresses the bacteria.
The people that didn't do their job, were they not doing their job, or did they have an idea that this
No,
would
they
happen?
didn't have any idea. They just disconnected some
They're like, he's out of
incubator and so on.
town.
Yeah. And so when he came back, he had to, go through and throw it all away, but he got suspicious. So antibiotic is a big part of our infection control. Okay.
Did you know, I have a kind of interesting story because you brought up World War II with penicillin and how many lives it saved. But Jack Daniels, the inventor of the famous whiskey, he died from a bacterial infection. And right now, today, it would be like nothing. But he got really mad when Prohibition started and he kicked his safe in his office and he got an infection in his toe and that killed him.
And do you know how many people who used to die if you have a trivial infection?
Yeah. And so today it would have just been a quick urgent care visit or something and he would have been on his way, but he died from it.
No, and
Should have never
for a very, very long time, an infection was a deadly disease without any repercussion that we can do. And they have done crazy things, like they would have done really crazy, like putting how do you call that, Jesus, the quecksilver in Germany, we say quecksilver, that mercury, that mercury in the wound and so on, everything that would damage a lot of tissue. And guess what? If you damage a lot of tissue, are you going to help or improve the infection? You make the infection worse because you're creating more dead tissue that your blood cell don't get. So antibiotic are access of our immune system to the infection area. So these are, we are getting there, okay? So, and then number of the cells there. So we are getting to the infection control for surgical purpose. Reduce number of the
Bacteria.
in the area you're doing surgery. Give them antibiotic and reduce the amount of the dead tissue you are creating. So you have the pillars of the infection control, for operative infection control. Let's start with the first one.
Sure.
Reducing the number of the bacteria in the area of the surgery. So tell me, what do you know about how do we do that?
Well, obviously, every single OR is immaculately clean before,
It
during.
is not immaculately clean.
The sterile field, the area that's being performed should at all times remain sterile. And there are things that go into effect if something becomes unsterile. But
Even the way you hold your hands needs to be.
yep, you have
At
to
a
keep
certain
them
angle
above
or
your
whatever.
waist,
This is actually, we did a study about that, this area is the most sterile one. Every 10 centimeter you go up and down, you lose about 10% sterility. So that's why where you hold your arm here, you don't do this or don't do this. That's how you, now,
Call
but
it my
first,
praying hands.
yeah, first of all, what you do is that it's every OR has a what we call HEPA, not HEPA filter, where the
Mhm.
bacteria get stuck there. And every OR has a higher pressure, meaning when you open the door of a OR, air is coming out, filtered air is coming out. Air is not coming back in.
Mhm.
Okay, that start with. But then before we go there, we have a routine of cleaning our hands.
Hands, yep,
Okay.
hand washing.
I'm going to tell you a joke. This is a real. When I was in for my first year of residency in Germany, there was this med student, just very fresh, very green. One of the residents told him to wash the hand. Not only that, that he has to as well wash under his arms and so on. And and everybody was outside, was watching him, the poor guy, doing crazy things. And well, that was really mean.
That was mean.
So, but what do we clean? We don't clean
Elbow
under the
down.
arm, elbow down.
Or sometimes.
And there is a routine to that, right?
Mhm.
You first, you put, depending on, I'm just going to talk about the new way, because the old way, you get the brush and you make your finger bleed and skin, injure your skin and so on. Forget about all of that. There are these solutions that are actually, look at my hand, they're so soft because I use them every day. Well, it's soft for me. And
Soft.
so
I
you
can-
put that lotion in, you dip your finger in it. First you put in your hand and you go all the way up here, up and down. Then you take another amount of that, and then you dip your finger in under your fingernail. If there is a clear soiling of your hands or dirty hand, obviously you have to wash it. But once you have done that, and then you just do your hands, and then you hold them up. You open the door with your back or push a button with your elbow and so on, and then you go there, and then the rest is they will help you to get dressed in a sterile way. And then at that point, everything on the waist and above is sterile, and every 10 centimeters you go up and down, you lose to certain percent sterility. So blue or green is the color of the sterility, and you don't get too close to it. You if you're not sterile. If you're sterile, you want to be as close to it as possible. Now, what's important there as well is that the way we clean the skin, we said, this is one of them, reduce the number of the agent. In the skin itself, and I'm going to just tell you what we do now. If there's an open wound, use the iodine or betadine, which practically kills everything, okay? And because that interact actually with the wall, with the chemical reaction with the wall of the bacteria, okay? But it's not, doesn't really destroy our human tissue, okay? Alcohol doesn't destroy both of them. That's why we don't use alcohol, or that's not the main thing. So, and you use either ChloraPrep or DuraPrep. You go in the area of the sterility, and then you go around it. You work, you don't inside out. And that's something we should make actually video. Actually, I did make a video about that. It is online, where you go from inside out, and then you don't come back in. You don't cross over the sterile area with your unsterile thing. So these are inside of the OR to reduce the number of the cells. Now, the second thing was with the sterility. Antibiotics. So who do we give preoperative antibiotic? Everybody.
Yeah,
That was my guess, was everybody, but.
I was sitting there thinking.
Yeah. What antibiotic should we give them?
ANSAP.
No, but let's go a little systematically about that. Why do we give them ANSAP?
ANSAP is a broad spectrum antibiotic.
Yes and no. Yes and no. What bacteria are we trying to make sure?
Gram-positive.
Gram-positive.
Yeah.
Yeah.
Not
So see, our
gram-negative.
skin is mostly
Positive.
positive. Our internal stuff is mostly gram-negative. Not exclusively, but mostly. Okay, so you remember they have a different kind of cell structure and it's different kind of sugar on the cell and so on. So for this things that we do, mostly gram-positive. We want to have a good gram-positive coverage.
Mhm.
It just happened to be ANSEF or cephalosporin. Cephalosporin, what is second generation, I believe,
Yeah.
has the best overall profile.
Mhm.
Because all these bacteria, they have a different wall, they have different characteristic, but it just happened to be that ANSEF has the best coverage for our skin flora. And that's what we mostly deal with. The night before, you ask them to clean their skin with what? HEPA
That
cleanse.
special shampoos
Yeah.
they send you home.
HEPA
with.
cleanse.
HEPA
Yeah.
I was just talking to a patient right before I came in here about her preoperative showers, and she's staying overnight the night before because she lives far away, and she's like, "Is it okay to do it in a hotel shower?" And I said, "Yes, it's okay."
You're just trying to reduce the number of the thing, yeah, and then obviously the day of the surgery, you know, the nurses make sure, and then we go there, and then we do our routine there, and so on. And then all of that with the OR environment to reduce the number of the cells there. What was the third pillar of the infection control?
So we have sterility, sanitation.
Don't give the bacteria food.
So a sterile dressing?
No,
No.
that don't create lots of dead tissue in
Oh.
surgery. Don't cause lots of things they love,
Mhm.
right?
Yeah, don't make a small wound bigger.
Do you know how you want to get best way you get rid of rats in your house? Don't have lots of food laying around that the cockroaches and so on. Don't put food around for them to come to you. They are attracted to something they can utilize.
Mhm.
So, and by reducing the damage to the tissue is the best way to reduce the infection. You guys know it now. What is our rate of infection in OLAF?
0.02.
0.02. What is the rate of infection, acceptable rate of infection for regular surgery?
7.
3 to 5%. And if you do complex stuff, up to 7 and 8. But, you know, imagine 0.2 versus 5%, 20 times more.
That is actually, you know, I think about these numbers all the time when you see, 3%, that's still
That's
pretty
high.
well for medicine, but you think 3%, that's, you know, if you were giving me 3% of your income, I'd be like, no, that's not that much. But when you imagine 3 of every 100 patients Dr. Abbasi gives surgery to is, you know,
Well,
no, not him, but if that were the case,
yeah, right.
you know, 3 people, that's a lot of people.
Right,
An
that's one
infection-
of the benefits of doing an OLIF,
Yeah.
because then you're just having a lot less damage too.
Exactly.
But the point there is every infection can be a deadly disease. You know, I have some TikTok, some videos about that, how we treat that. You look at that, and you know, people have died today of infection disease. Now, then all of a sudden 0.2 versus 3% is a big deal. Now, what's important is that those 0.2%, not a single take back to surgery, because in OLAF, we don't cut the tissue, we don't cook the tissue. That's how we stop the bleeding, the surgery. We don't put lots of retraction on the tissue, which prevent the blood flow and causes dead tissue. So all those 3 injections, they were superficial infection, never take back to surgery, that reacted or improved with 5 days of Keflex. Not a single take back. So all of a sudden, like infection in the spine is a thing of past because we don't create dead tissue. And again, we create dead tissue by cutting it, cooking it, and then putting pressure on it. And then all of that accumulates in more medium for the bacteria to grow and more space, because if you open the fascia, any superficial infection can become a deep infection. So in my surgery, you will see that I don't use bipolar coagulation or Bovi for the OLAF. I just tamponate it with the sponge, and that reduces the chance of more material for the dead tissue. Now, still, you know, some other people do other surgeries and they have infection, and we have other for other kind of surgery. We do have still some infection. We just had recently infection.
Mhm.
Once you have the infection, what are the clinical signs of infection, Alexa? Alyssa?
Fever, warmth. Oh,
The,
It's not like-
There's all the Latin words.
yes.
Oh,
all
the
the
pallor and rubber and.
the rubor is
So
right.
redness,
3 hours.
redness, pain, and swelling, and then like loss of function gets thrown in there.
Do you guys remember what the Latin words are?
Just
Rubor.
rubber.
Dolor is pain.
No,
Dolor is
I can't 3 hours. It must be some
Oh.
R involved in that, but it is
I got
swelling, pain, redness.
Swelling pain redness.
Okay. Have you heard in all med school they teach that? It's called obi pus ibi evacua. It's a Latin word for wherever pus, remove it.
Mm.
That is 2,500-year-old, meaning that what is the pus? What is it?
It's a kind of a pile of white blood cells around something that's making the white blood cells build up, which is usually
It's suicide.
bacteria.
To all bacteria. When you have an infection, your body, if you have a good immune system,
Mhm,
start a reaction to fight it.
mhm.
One of the reaction, and there are different pathways. We are not going to bottom of it today, but one of the reaction is walling it off,
Mhm.
meaning our immune cells, they come and make a barrier. And then other immune system, they go inside of the barrier, they kill themselves, they eat them. So or some other, they go and not only eat them, they then dissolve themselves, all the enzymes there, then attack the bacteria. And the combination of this wall and the other cell that they go in and eat them and then release the enzyme is that milky material that we call it pus or purulent discharge. If you have a lot of that there, meaning there's at certain point, that material itself become a medium for bacteria. So you want to remove it. So what the worst thing you can do to a purulent discharge that's coming from anywhere of your body?
Push it in deeper.
No, close it off.
Oh,
Closing it off.
because I was thinking I've seen people that close rupture like a boil and it just pushes it deeper into their deeper
No,
tissues.
you wanna lance a point.
Yeah,
And who used to do that? Barbers.
yeah.
Because they have the sharpest knife. So you wanna open it up and let it drain and keep it open.
Mhm.
Mhm.
And that comes to the next point, when you get an infection, it can be focal, it could be systemic. What is the difference?
So focal is localized to one spot, but it hasn't gotten into your circulatory system. You haven't mounted like a full body response to it.
What do we call a full body response to infection?
Sepsis.
Sepsis is a deadly disease. So if you wall off a focal infection and you don't let it drain, you can make it a systemic infection, okay? So never close a draining infection.
That's why I said the worst thing you can do if you have a boil is a closed rupture where you
Push it in.
pop it, but it goes deeper inside.
Yeah, you can open it up if it's really big. You can
Mhm.
open it up with a needle or something
Mhm,
and then let it drain
Mhm.
to outside,
mhm.
but never, keep it and push it more in because you remember our body comes and make a wall, a capsule around it.
Mhm.
If you just push on it randomly, you're disrupting that capsule, that
Mhm.
barrier that your body is trying to build around it. So don't push on it now.
I
If
say one thing I would say, because we see a lot of pimple popping videos and they always say, don't pop it, don't touch it. This also comes with a lot of what we're saying is the people that will be cutting these open are doing them sterilely, eliminating or trying to prevent that infection. That's part of the reason why they advise you not to do it
No.
at home.
have you learned about that triangular space in your nose
Yep,
that you
yeah.
absolutely should let them be?
The triangle of death, because the drainage goes into the cavernous sinus. and
Yes,
can-
it goes inside of your brain.
Yep.
That meaning that you can
Like that.
retrogradely push that bacteria inside of your brain. It's rare. It's very rare. Okay, so I still don't recommend it, but don't go.
No, just don't pop your pimples. It's gonna end up getting uglier. It's gonna get redder. It's gonna scar, scab. Just leave your pimples alone.
I
Yeah.
actually had a professor who was teaching us about that, and she had a childhood friend that had died because I don't know if it was a pimple or if he had gotten some sort of wound or sore, but it had led to an infection. in his
That is
brain.
not to do that. but these days
Yeah.
that should be a very, very rare
Yeah.
thing, you know?
Yeah.
So, okay, we have done the surgery properly. We reduced the number of the bacteria. We reduced the amount of the dead tissue. The patient still come back with the infection. You looked at it's not systemic, because if it's a systemic, you send them where?
So the ER.
Right away.
Mhm.
Okay, how do you understand what are the systemic sign of sepsis?
So you'll get tachycardic, fast heart rate. You'll
They are
be,
sick as a dog.
yeah.
Yeah, they'll hit multiple organ systems.
I'll be
Iris.
surprised if they make it to your clinic. Because if they don't call 911 when they're that sick,
Mhm.
then that means that, you know, it's something else is going on, because it's rare not to recognize somebody sick as a dog. But there are certain signs there too, you
Mhm.
know, you're pale, you are dusky, your skin is dusky, and so on. There's a group of people that they can have a sepsis, but not have all the sign of sepsis. Do you know where I'm going?
If they're immunosuppressed.
Excellent. That's it. Because obviously their immune system doesn't respond.
Sure.
They die, still die,
Mhm. Mhm.
but the
They
immune
just don't
system,
show it.
they just
Like,
don't show it. Hello, how are you doing?
Mhm.
Dead. Okay, so but beside that, it would be rare to not have this. And now, let's say we eliminate that. We have a focal infection. They come to your office. You did everything as booked, and still they can have an infection. That's okay. So, and you have all the local sign of the infection. But what next? What do we do?
So
The purulent discharge.
we'll want to culture that so that we
Very
can
good.
figure out what it is.
How
and
do you
what-
culture them? Let's talk about the
You,
culture.
so you get a little swab and you try to avoid touching the outside as much as possible and get just the
Mm.
pus, and you stick it in some medium and you grow it out, and then they'll culture it and see what antibiotics it's susceptible
What
to.
is it called? What's called that?
Culture and sensitivity.
Culture and sensitivity or antibiogram.
Yeah.
So meaning that they put some of that bacteria, they grow it, and then put it on different medium
Mhm.
and see not only which one works to which one works best, because
Mhm.
they can have colonies and so on that they can literally tell you that this is that effective, this is that effective, and the numbers come based on how many colonies
Mhm.
are still developing with that or not, at what dosage. So it's a very good test, tell you which one is work the best or not, but that takes time.
Yep.
You're not going to
Couple
wait
days.
for that,
So
are
then-
you?
No, so then you start them, you can take kind of your best guess. If there's any necrotic tissue, gently removing that so you get rid of the food source for the bacteria.
Exactly. So now the infection we just had, it wasn't Olaf, it was different kind of surgery.
Mhm.
But one of the things we did is that I took a small little gauze,
Mhm.
dry,
Mhm.
and just literally, what did I do?
You
Put it in
kind
the
of
wound and just
rubbed around kind of
rubbed
gently.
around to remove all
Yep.
the dead tissue. And that it brings us to one of the things, you should pack it so the opening stays open.
Mhm.
The packing of a wound, infected wound, is to just keep it open so everything drains out and nothing drains in.
Mhm.
And what do we pack them with?
So for this particular case, we did a wet to dry dressing. So we used sterile water in a very small amount, and then it was and sterile gauze. And then
Does it have to be sterile?
I would prefer it to be sterile.
Yes, but it doesn't have to be sterile. It's already infected.
Yeah.
Everything is already there. So if if you don't have sterile thing, don't not do it because you don't have sterile stuff. Just use a water from the faucet.
Mhm.
It is better to do that. Obviously, use the sterile stuff if you have it.
Mhm.
But if you don't have sterile stuff, there's no excuse
Mhm.
still not to do the same thing. Because it's already
Mhm.
infected. It's already there. So you pack it barely wet, you let it dry, and then it sticks to the dead tissue when you take it away. That's what the wet to dry dressing is.
Mhm.
And you want to keep that space open. Now, there's some other stuff you can pack in that as well have some antibacterial properties. That is the focal control that you get rid of food for bacteria. You debride the dead
Mhm.
tissue,
Mhm.
okay? And sometimes in the war, if you take them back, we have something called jet lavage. Have you heard of that?
Yeah, where it's just like you
And
kind
I
of,
have a nice YouTube about it, how to use it, how to do wound vac and so on, and all of that, the wound vac. So with jet lavage is actually like a water pistol that you use antibiotic irrigation, preferably combination of antibiotic that has both gram-positive and negative, and with pressure, it shoots it at the tissue, all the dead stuff, they fall off, the live tissue stays on,
Mhm.
and then this antibiotic get impregnated in the tissue. It gives you a local focal infection control, and it sucks the things out as it shoots and sucks it out. And then once you have done that, sometimes we do so-called the wound vac. Have you heard of that?
Yeah.
It is almost like unbelievable. That is, I think one of this is a major innovation in the infection control. Explain for people who don't know that what a wound vac is.
It kind of creates a negative pressure so that and it covers the wound, and it creates that negative pressure so that nothing goes into the wound, and anything that's bad in the wound gets kind of drawn out.
Drain. It's kind of like a drainage
Yeah.
system, and then you
You-
can empty it.
Like a
You-
vacuum.
Yeah, you remember in the war, we said in the war, pressure is higher, so
Mhm.
air goes out, not in. Here, opposite, we put a vacuum or just reduce the pressure. It's about the difference in pressure. Reduce pressure outside, so everything inside comes out and nothing goes in. It has another effect that is extremely important because it's two other effect. Because it's a negative pressure, it perfuses the tissue.
Mhm. Draws blood.
Yeah,
To the
draws
area.
nutrition to the our life tissue.
Mhm.
And it has another effect that's extremely important. Imagine you have a wound that this big.
Mhm.
You put that wound vac, reduces the
Mhm.
wound, and it makes the actual mechanically reduces the size of the wound. I have seen horrendous thing that respond to wound vac so beautifully. Definitely, we are going to do some of that together because it's just a matter of statistic. Even though our infection rate is so low, we still do some other surgeries that must be done the traditional way. So we will see that. So fortunately for the patient, unfortunately for you, you will not see a lot of infection in our service. Okay, so every exposure you get to infection, come and learn from it. Okay, because you cannot miss anything about that. No, we debride it, we clean it, we put a wound vac, or we just dress it wet to dry, but then we cover them with some general antibiotic. What antibiotic would we give preferably?
On like a wound or like
Wound infection, yeah. Before we
Like-
have the
like
antibiogram, or
so I personally like doxycycline because it has really good skin penetration,
yeah,
but I know that a lot of people like to use like Keflex.
Yeah, I say that's
Keflex is practically
skin,
the
that's not
oral
your-
version of Ansef, has the
Mhm.
best overall skin flora, and most of the surgical infections are skin flora. Again, not too bad, but in the wrong place to wrong number.
Mhm.
If you have some nasty infection like Pseudomonas and some other, obviously you have to do antibiogram and the sensitivity test and so on. But for that reason, just to not miss them, I like to give as well something that has as well a gram-negative coverage, not only one gram-positive coverage like Ansef, which is beautiful. What should I give that has a good gram-negative coverage as well? So I
Like
always
a-
I double them.
Like a fluoroquinolone, so like levofloxacin.
Perfect. Perfect. Levofloxacin or clindamycin
Mhm.
has a good gram-negative coverage. So by bunching it with Ansef, it has give you good overall coverage until you have a better understanding of what's going on. Now, we talked about to top it off. We are talking about, is it boring for you, Amanda?
No,
Are you enjoying our
yeah, I'm
infection?
really learning a lot.
Yeah.
It's the crossword word of the day, levofloxacin.
Yeah, if I could spell it.
Yeah, that's why we say Levo.
Levo, yeah.
Oh.
Yeah. it's-
Now you see, now for the first time, we are bunching up on Amanda. Usually everybody bunches on me. No, we are talking about that, this medical stuff. And so, but it is important because I think for lots of people who listen, that is a practical how we deal with that. Now, let's talk about a little about top it off with the preoperative antibiotic. We give ANSEF or what? What are the alternative to ANSEF if somebody has, let's say somebody has
An
allergy to ANSEF?
Well, you just kind of mentioned it, but clindamycin. It's a
Very good
one.
coverage. Yeah, clindamycin. Now, some people unfortunately think they can always replace ANSEF with vancomycin. Not my favorite. Why is vancomycin not my favorite antibiotic?
Well, there's a lot of, I hear a lot of resistance starting to come for Vanco because of how often they're overusing Vanco with the MRSA coverage.
Or like
but
vancomycin resistant.
that's
enterococcus.
insane.
But my reasoning would be, one, it's hard to dose. Two, you have to worry a lot about kidney problems because
Not for one
Dose.
dose for perioperative antibiotic. Now, is a 9mm pistol the same like a 45 Magnum?
no.
No. So antibiotics are not same, don't have same effect on all bugs. For most of the skin flora, ANSEF is a 45 Magnum. Vancomycin is it's a 22
Yeah, 22
small
caliber.
caliber.
Yeah.
Okay, except for one certain strain. For that certain strain, it's just the opposite.
Mhm.
Vancomycin is a 45 Magnum. What is that? Was it that strain?
MRSA.
MRSA. So if you have MRSA, so vancomycin is weaker in every other category except for MRSA. That's why I don't like to replace
Give
it.
it, yeah.
So what do we do if somebody had a MRSA, history of MRSA? We double it. We give ANSEF and vancomycin. Definitely not replace the ANSEF, but what's important that you need to pay attention to that. Never give vancomycin and ANSEF through the same line at the same time. Why? The chemical molecule that participate, they build a crystal, both of them become ineffective. You have to give it through different lines, or you have to give the first vancomycin, wait, and then give the
Is that Vanco with like all cephalosporins or
with
just
with
no
most of
answer? Okay,
let's
just a rule of thumb, just
let's
kind of
just
avoid.
separate them.
Yeah.
Okay, let's just not go to risk it.
Sure.
Give it through different lines, or first Vanco and then ANSEF, give them both. Now, what about if somebody has a penicillin allergy?
I have a penicillin.
Well, you can
You
still,
do? What happens?
And hives.
You still get ANSEF.
yeah, I'd give you that.
Yes.
You know, it's actually, this is kind of a side note, but if you have a penicillin allergy listed in your chart, your odds of dying in a hospital are a lot higher.
I believe that.
Significantly higher.
100% believe that.
Because then they have to use more risky antibiotics for you, and they have less coverage of antibiotics. if you
I
get
don't think I'm
infection.
allergic to it anymore.
So now, and people grow out of it. That is important. If you have penicillin allergy, go recheck it. Okay, this is almost like almost crazy, and you will notice that people come with a list of 23 allergies.
No,
Most of them are side effect, not allergies, and you might as well go to a building and drop yourself down
Mhm.
by accepting all those allergy lists on your thing, because you're going to reduce the care we can give you so tremendously. He just said it. You're even no, and people confuse the allergy with side effect, like, oh, I get nauseous and so on. No, it's a side effect. Like I get constipated.
yeah, I was gonna say, what is like one of the number one causes of antibiotic use is gonna be like diarrhea or and/or constipation, GI
Yeah.
issues.
Allergy is a different kind of response, and people are too liberal, too loose to applying them, and that is a deadly kind of problem. And then nobody dares to give you what you need because they think the allergy is allergy, and nobody can fault them for that either. So they'll watch you die rather than go to the bottom of it. That for that reason, no, if you think you have allergy, go to an allergy specialist, get them damn off your list. Now, if you truly have an allergy to penicillin, that and that the hives is a allergic reaction, could be allergic, but in some other thing, hives could be as well a side effect. So it's a big deal. What they do, they put a little bit of it on their cutis, very little of it, within the cutis, and then they see if your immune system react to that. Okay? Because if it's true allergy, your body will react to that in a very specific way. So we can't find out. But let's say you do have allergy to penicillin. First of all, penicillin, we discovered it like 70, 80 years ago, and then we discovered we can modify the molecule certain way, and then we to become more effective in certain situations for certain strain. We call them cephalosporin generation 1, 2, 3, and 4 now.
And 5 now. We're up to
And so-
5.
Wait, when did this 5
We're
come?
up to number 5.
Yeah.
Oh.
So, but you notice that there is because there are variation of penicillin, that people who have allergy to penicillin might be as well allergic to cephalosporin, at least generation 1 and 2. What is that cross reactivity?
25%.
That's what we thought.
Is it less than
3.
that?
It's less than
3?
3. Less than 3. So
That's a big difference.
yes, and that is the reason, except if you have anaphylactic reaction to penicillin, you still should give ANSEF for all our patients.
Hmm.
And that is nationally standardized now, okay? So they still will call you and say, and you ask, what was the reaction? We don't know, or it's a hive, or anything but anaphylactic, you still give the ANSEF. If in question, you make a test dose, and then you go from there, okay? So still the preference is ANSEF, except if there's anaphylactic, but then you do clindamycin, not vancomycin, okay?
Do you typically give anything with if they have that allergy, like some sort of like, not necessarily Benadryl, but
Yeah, you can give Benadryl, you can give anything you want.
but you don't.
No, well, not anything you want. You can give any antihistaminic
Yes.
medication, okay? So
Sure.
they understand what I say. You don't give everything you want. You give
An antihistamine.
And-
Yeah, it's not that
antihistamine.
nurse.
Yeah, but they people in medicine, they understand that, okay?
Yeah.
So, okay, we saved life. We prevented the sepsis by making a local infection stay local and get rid of it. We did everything before and everything after and so on. Now there is a problem. There are certain infections are very, very hard to get rid of. Do you know what those infections are?
If it's a infection that's localized to a prosthetic,
Well, that
Why?
too.
because the prosthetic doesn't have its own blood supply, since it's not our own body.
Very good, very
So
good. You
we
have done,
can't
you have
reach
done, yeah, not we.
Well, yes, well, if
Our
it was,
immune system.
if it was your prosthetic, then it would be you.
No, well, our immune system cannot
Yes,
reach it.
yeah,
An antibiotic cannot reach
Mhm.
it. Okay, so there are some crevices of that thing that one bacteria survives, and as soon as you get rid of everything else and stop the antibiotic, the infection come back. I had a patient that 3 times I did that and everything was beautiful, and then 3 weeks later, infection comes back. What now?
You need to remove it.
Remove and irrigate.
Remove all the dead tissue, including the screws,
Mhm.
including the
Everything.
hardware, because they are at the end of the day dead tissue.
Mhm.
Okay, that's not a trivial decision to make. So, what's important? You have the number on your speed dial. Okay, so we will deal with the infection together. So, this is actually pretty much most of the perioperative infection control. There are lots of different situations, lots of different things that we need to still, consider and so on. But, what question do you guys have?
I just think that the most important part of all of that is the prevention of it.
Yeah.
Doing whatever you can to
Mhm.
prevent the infection is going to make your
Statistically,
life
you
easier.
cannot.
But
It's
do the
always going
best
to
you
be. You
can.
do the best you can.
It's just super important. I mean,
Yeah.
that's like one of the things that they taught us all the time is, you're going to go into the ER on these rotations and you're probably going to break sterile field.
Mhm.
Do not lie about it.
Mhm.
It is not about your conscious, how you feel, how
No.
embarrassed you are. This is the person and their, life.
They're trusting
potentially,
you.
And that
if,
is,
you know, that was just a big thing for
Yeah.
me is, it is the prevention. It
Yeah.
is not the
Let
do
them,
now, ask
let them
later.
look at, let the scrubnik look angry at you.
Yeah.
But still, you know, but we have those things like, you know, if you touch something, you have this sleeve,
Sleeve, yeah.
you're prepared for that. This is happening all the time and so on and so
Exactly.
forth. And so rule of sterility, like if something is like drop off your field, you don't pick that up anymore. You would be surprised.
I actually just saw a TikTok.
You
on-
actually, you know how athletic I am. You know, my first thought is when, you know, when things get dropped is to catch it, right?
Yeah.
And that was my first ever,
Don't
first
catch
and
knives.
last ever sterility issue was, you know, a surgeon dropped something and my first thought was to go out and grab it to catch it before it hit the ground, sterile, you know,
Well,
and then I forget the little bubble and everyone goes,
Yeah,
don't grab it.
then grab it within the bubble, but not outside of the bubble.
Yeah,
okay?
so it's
And in the surgery, we have lots of sharp stuff, so don't
you
catch
don't
them.
have it,
That's
Juggle.
what I was
Catching them.
wondering, like, what's she trying to
Your first
grab?
thought is, well, you know, if he drops his Bovie, you have to spend 5 to 10 minutes stringing that thing back through and
I
do.
hope not that long, and I don't use a
Well,
Bovie for my
you
surgery.
don't. My knee replacements, yeah, they
So,
do.
I know, but this this become a part of you when you're a surgeon or you're in the surgery. This behavior there become a part of you. You automatically will do the right thing and so on,
Mm.
and you won't feel embarrassed after a while if you you just, hey, yeah, give me a new glove, or I have to regown and so on and so forth and so on. It becomes a second nature to you, and you are prepared for that. Just do the right thing,
Mhm.
and you will. So I'm not confused about that. Now, there is a way we live inside of the wall. There is a way we behave inside of the wall. I say live because I truly sometimes live there. And and those rules, if you condense them, they all come to these 3 pillars of infection control we talked about, which are
So
Don't kill the dead tissue, antibiotics, sterility.
well, reduce the number of the cells
mhm.
of the bacteria. Yeah.
You're changing the pillar titles on
No,
me.
the
I mean, I
title is
kinda
not
just-
title, it's the idea.
It's an umbrella.
3 ideas.
I just pre-op, intra-op, post-op.
There you go,
That's
nailed
great.
it.
So, and all 3 applies, you know,
Mhm.
that like don't create dead tissue.
Yeah.
Applies to after the surgery as well, because you know if somebody comes and you put a lot of pressure on their tissue and they don't perfuse,
Mhm.
Yeah.
and then as well you know it applies to before the surgery.
Mhm.
Like we used to get a razor and shave the skin,
Mm.
Oh,
or ask people to go and shave that area. We don't. We clip them, or it's better keep the hair on than go and use a
Mhm.
razor.
Mhm.
So they are not specific to a certain time. They are apply across the board. So
Sterility.
attack the bacteria, or
Limit the amount of
Antibiotic?
bacteria where it should not be.
yeah, and limit the amount of the bacteria, and don't create the dead tissue. And but once you understand the concepts, you know, and every moment you understand, you know, what to do in that specific moment. Okay. Anything else?
Well, I'm sure there's a ton more, but I think that was a really
I
good
think- I think-
Yeah, this
basic
was good.
refresher.
I
Like,
think,
that was.
yeah, we should do.
Amanda's ready to be done.
Yeah.
No, Amanda's ready to go perform surgery.
I am.
No,
I'm ready.
Amanda suppressed few yawns. I saw that. We should
Hey, at
put on
least
the
she
podcast
suppressed
rules.
it.
Don't yawn on camera.
You
Tried
can't
doing my mouth
blame
set.
her. You
Yeah,
can't blame
that's
her.
what-
It's Friday. It's Friday. You can't blame her for
See that?
yawning.
You see how excited they are, though. You see?
And I'm really
This
happy.
is nerdy.
No, it's not nerdy. This
This
is
is for Amanda.
something-
She looks at me and she
something
goes,
you are guys are going to live. It's something you guys are going to live. Now,
I'm happy that you guys know this because although I'm not going to be performing surgery, someday in my life I will be having surgery. And I think it's important for
pick me.
I think it's important for everyone to keep these rules in mind because they're even though like what's the infection rate with Olaf?
0.2%,
0.
3 to 5%, 20 times more.
Yeah, even 3% seems like a small number, but that's so much bigger than 0.2. So these rules,
These
even
are
though to
people.
me they're
Yeah.
maybe boring, they're still important.
Well, I think that we should do some TikTok or content about actually how do we
Creating a
Did you-
sterile field,
all the-
creating
all the-
a.
Did you get a
and
chance
separate
today
care.
in Maple Grove to do that? TikTok? I asked.
But
Oh, we
I
should
have
make some
another
TikToks.
question.
Oh, question. I love
Well,
questions.
this is more about, have you been wearing the dosimeters for our study?
Yes, I
You
have.
been, okay.
Yes, I have for those that are appropriate. Yes, I
good.
have.
Well,
So-
thank you guys.
So I thank you for listening to this nerdy stuff, which are medical stuff. But if you are a student, med student, resident, and in any medical profession, these are, I think, very important information for you.
Thanks for watching. I'm Amanda Armagast.
I'm Melissa Haber.
I'm Mike Yeager.
And I'm Dr. Abbasi.
Have a good weekend and be safe. Happy St. Patrick's Day.
Happy
Stay-
St. Patrick's Day.
Stay infection free.
And go to your allergy doctor.